We'll be breaking down all major concepts covered on the exam. But first, imagine this scenario. A patient comes into your clinic, completely blind in one eye, and they are in excruciating pain. And then an hour later, another patient walks in with, just a mild, painless, but gradual weakness in their leg. Counterintuitively, on the MCCQE, that blind patient actually has a much better long-term prognosis. Today, we're finding out why.
Welcome, everyone. If you are a Canadian medical student gearing up for the MCCQE, you are in exactly the right place to get some answers. I'm Donna, and alongside my co-host, Harvey, we are your MCCQE reviewers.
Yeah, our goal today is to make your exam review process a whole lot more comfortable. We really want to strip away the overwhelm, and just get right to the high-yield facts.
Right.
So today, we are pulling from highly reliable StatPearls articles to tackle this massive, heavily tested topic in the neurology section. Specifically section S08. We are taking a deep dive into multiple sclerosis.
It's a huge topic.
It really is.
Yeah.
And our mission is to extract the absolute must-know points. So the classic presentations, the strict diagnostic criteria, management strategies, and crucially, the traps they love to set for you on test day.
Oh, they love those traps. And before we get into that clinical material, let me just provide a very quick standard disclaimer. This deep dive is intended strictly for medical education and exam preparation. It is not medical advice. Clinical decisions should always involve a qualified healthcare provider.
Perfect. Okay, let's unpack this. Before we can confidently diagnose MS on an exam vignette, we kind of need to know what the disease is fundamentally doing, right?
Exactly.
And we need to know exactly who is walking into our hypothetical clinic. If we're visualizing the absolute classic demographic profile for the boards, who are we picturing?
So the classic patient profile you really want to look for is a young adult, typically between 20 and 40 years old.
Okay, 20 to 40.
Yeah. And gender plays a huge role here. The disease is roughly 3 times more common in females than in males.
Wow, 3 times.
Yeah, it's significant. So if your vignette features, say, a 28-year-old woman presenting with sudden, strange, unexplained neurological symptoms, MS should immediately shoot to the very top of your differential. It's the most common immune-mediated inflammatory demyelinating disease of the central nervous system.
Right. And when we say inflammatory demyelinating disease, I want to look at the actual microscopic pathology. Like, what is fundamentally happening inside the brain and spinal cord that leads to these symptoms?
It's essentially a highly targeted, inappropriate immune attack on the insulation of the nerves.
The myelin.
Exactly. Under a microscope, you would see paravascular lymphocytic infiltrates, specifically mononuclear cells, and macrophages that are actively degrading the myelin sheaths that surround the neurons.
Oh, I see.
And these focal areas of inflammation and myelin loss, they form what we call plaques. You'll see this on the exam. They predominantly center around the small veins and venules in the white matter.
Here's where it gets really interesting, though, regarding why this happens in the first place. Because the source outlines 2 main pathogenic theories. And I kind of like to picture this using a castle analogy.
Okay, let's hear it.
So the most widely accepted theory is the outside-in hypothesis. Think of your central nervous system as a fortified castle, right?
Yeah.
Perfectly protected by the blood-brain barrier.
Right.
In this scenario, rogue CD4 positive T cells, specifically Th1 and Th17 cells, are the invaders. They get activated by some unknown antigen outside the castle. They attach to the endothelium, breach the castle walls of the blood-brain barrier, and start an immune attack inside through cross-reactivity.
That is actually a great way to visualize it. And, the alternative to that is the inside-out hypothesis. If the first theory is a foreign invasion, this second theory is a rebellion starting from within. It suggests there is an intrinsic central nervous system abnormality, something fundamentally wrong with the myelin or the oligodendrocytes themselves that, suddenly triggers an inflammatory response. It calls the immune system in and causes the tissue damage.
So we have an invasion or a rebellion. But what actually triggers these T cells to go rogue in the first place? Looking at the sources, it seems like a really complex triad of genetic susceptibility, immune dysfunction, and environmental factors.
Exactly. It's the classic combination of genetics loading the gun and the environment pulling the trigger.
Yeah.
Genetically, the HLA-DRB1 star 1501 allele is strongly correlated with MS. To put the genetic risk into perspective, if a patient has a first-degree relative with MS, their risk jumps from roughly 0.1% in the general population up to 2 to 4%.
Okay, that's a big jump.
Right. And in monozygotic identical twins, the concordance rate is remarkably high. It's between 20 and 30%.
Which proves genetics alone aren't the whole story, right? Otherwise, identical twins would have a 100% concordance rate.
Precisely.
And that brings us to the environmental trigger. The sources mention Epstein-Barr virus and vitamin D deficiency. But I have to push back on one specific environmental detail because it always trips me up.
Sure. What is it?
Epidemiological studies show a distinct latitude gradient, meaning there's a higher prevalence of MS in northern latitudes like North America and Northern Europe.
Yes.
But the text notes that if a population migrates from a low-risk sunny area to a high-risk northern area during childhood, they adopt that higher risk. Why does moving to Canada when you're 10 years old change your risk profile so dramatically?
Yeah, it's wild. But what's fascinating here is that it points to a critical developmental window. It's not just about where you live at the moment you get sick. It's about what your immune system was exposed to while it was maturing.
Oh, I see.
Moving to a northern latitude during childhood means significantly less sun exposure during crucial developmental years. That leads to lower vitamin D levels. And vitamin D is known to be a highly potent immunomodulator. It basically helps teach the immune system tolerance.
So you combine that early deficiency in immune regulation with an encounter with a common pathogen like, getting the Epstein-Barr virus, plus an underlying genetic susceptibility, and you've essentially created the perfect storm for an autoimmune response later in early adulthood.
You got it. The immune system is miscalibrated during childhood, and it misfires in adulthood.
Okay, so what does this all mean for the clinical vignette? We know who gets MS and the pathophysiological why, but when they walk into the clinic, how do they present on the test? When I look at the clinical presentations, it seems like the exam focuses heavily on the brainstem and optic nerves. I'm seeing a lot of unilateral vision loss.
Yes, because we are primarily talking about relapsing remitting MS, which the sources emphasize is by far the most common course tested.
Right.
And you hit the nail on the head. Optic neuritis is a classic, highly specific presentation. It usually presents as painful unilateral vision loss. The patient will say it hurts to move their eye.
Oh, wow.
Another buzzword symptom is the Lermit sign.
Right. That's the one patients describe as an electric shock sensation traveling all the way down their spine or into their limbs when they flex their neck forward.
Exactly.
It paints such a vivid picture of a spinal cord lesion, short-circuiting when it's stretched. But the one presentation that always screams board question to me is internuclear ophthalmoplegia, INO. Can we break down the mechanics of what is actually happening with the eyes there?
Oh, absolutely. INO is a brilliant test of neuroanatomy. It is caused by a demyelinating lesion in the medial longitudinal fasciculus, or the MLF.
Okay.
Think of the MLF as the communication cable that tells your eyes to move together. When a patient with INO tries to look to the side, say they look to the left, the affected right eye fails to adduct. It simply cannot look inward toward the nose.
So it's stuck.
Yeah, mostly. Meanwhile, the left eye, which is abducting and looking outward, develops a beating nystagmus. The communication cable is cut, so the eyes just lose their coordination.
So if you see a young woman who can't look inward with one eye, you should be thinking MS immediately.
100%.
And then there's the Charcot neurologic triad: dysarthria, nystagmus, and an intention tremor. It's a textbook constellation of white matter and cerebellar signs. But I want to talk about a phenomenon that genuinely confuses me every time I read it: the Uthoff phenomenon.
Ah, yes.
The heat.
Right. It's described as a worsening of neurological symptoms when the patient is exposed to heat.
Wait, so you're telling me a patient gets into a hot tub or takes a hot shower and their immune system suddenly decides to launch a brand new attack on their brain? How does heat trigger an autoimmune response?
It doesn't.
It doesn't.
No, and that is a crucial distinction to make for the exam. Heat does not trigger an autoimmune response, and it absolutely does not cause a new demyelinating lesion.
Oh.
If we connect this to the bigger picture of basic nerve physiology, it makes perfect sense. The Uthoff phenomenon is strictly a temporary physiological short circuit. In a healthy nerve, the thick myelin sheath allows for fast, efficient electrical conduction. But in an MS patient, those sheaths are damaged and stripped away.
So the nerves are already barely hanging on, trying to conduct the signal.
Exactly. And when you raise the body's core temperature, even just slightly with a hot shower or exercise, the heat physically alters the sodium channels and slows down axonal conduction in those already demyelinated nerves.
Wow.
It slows it down so much that the signal fails entirely. The old symptoms flare up. But once the patient steps out of the shower and cools down, the conduction improves and the symptom resolves completely. No new damage was done.
That makes so much more sense. It's a symptom flare caused by physics, not disease progression caused by the immune system.
Right.
Okay, so we've established the classic presentations. But the MCCQE loves to test our ability to recognize when we're, barking up the wrong tree. What are the atypical features, the red flags that should make a test taker stop, put down their pencil, and realize they're dealing with a mimic?
The first major red flag is age. Since we are dealing with a classic autoimmune timeline, an onset before age 10 or after age 50 is highly atypical and points to something else.
Right.
Seizures are another massive red flag.
Because MS is a white matter disease, right? And seizures originate in the gray matter cortex.
Exactly. So if you see cortical deficits like seizures, aphasia, apraxia, or early onset dementia, you should immediately point your differential away from MS.
That's a great tip.
And finally, pay close attention to the tempo of the symptom onset. MS relapses are subacute. They develop over hours to days. If the exam describes deficits that develop incredibly rapidly, within minutes, you should be thinking about a vascular event. That's a stroke, not MS.
So if heat just causes a temporary short circuit without doing new damage, how do we prove to the MCCQE examiners that actual permanent damage has occurred? That requires proving space and time. We have to transition from our clinical suspicion to the gold standard diagnostic workup using the McDonald criteria. What is the core logic behind this criteria?
The absolute bedrock of an MS diagnosis is proving dissemination in space, or DIS, and dissemination in time, or DIT.
Okay, DIS and DIT.
Right. For dissemination in space, you need to see objective MRI evidence of damage in different parts of the central nervous system. Specifically, the scan needs to show T2 hyperintense lesions in at least 2 of 4 specific anatomical sites. Periventricular, juxtacortical, inferentorial, and the spinal cord.
And a quick high-yield visual for the exam, you'll often see those periventricular lesions described as ovoid and oriented perpendicular to the ventricles. They're sometimes called Dawson's fingers.
Yes, very classic.
They look like ovals radiating outward because the demyelination physically follows the path of the small venules branching off the ventricles. Okay, so that establishes space. We've proven damage in at least 2 different zip codes in the central nervous system, but what about dissemination in time?
So historically, demonstrating dissemination in time was incredibly frustrating because it meant proving that these lesions occurred at different, distinct moments in the patient's life.
Right, which takes time.
Exactly. You'd either need to wait for a patient to suffer a second, brand new clinical attack, or you'd have to wait months, do a follow-up MRI, and prove a new lesion had formed compared to the baseline scan.
Sure.
But the 2017 revisions to the McDonald criteria made a massive change that every student absolutely needs to know.
Okay.
You can now establish DIT instantly by the presence of cerebrospinal fluid oligoclonal bands.
See, I want to push back on that from a practical exam standpoint. If an MRI already shows bright white lesions in the brain and the patient clearly has neurological symptoms, why would we ever subject them to a painful lumbar puncture just to look for oligoclonal bands in the spinal fluid? Doesn't the MRI give us the answer?
It's a fair point, but this raises a profoundly important question about treatment delays and protecting the brain. The 2017 update was revolutionary precisely because it eliminates the waiting game.
Oh, so?
Before 2017, if a patient had a single clinical episode, say, their very first bout of optic neuritis and their first MRI showed lesions in multiple spaces, you had dissemination in space, but you didn't have time.
Because it all could have happened once.
Right. You had to send them home and essentially say, wait until you go blind in the other eye or your leg stops working and then we'll treat you.
Wow. That's terrible.
It was. So finding those oligoclonal bands in the CSF proves that there is an ongoing chronic immune response happening right now. It establishes dissemination in time instantly at that very first clinical visit.
Yes. It means you don't have to wait months for a second MRI or a second devastating clinical attack to finalize the diagnosis.
Right.
You can initiate disease-modifying therapy immediately, protecting their brain from irreversible damage.
Exactly.
Time is brain, and time is myelin. I love it. Now, before we lock in that diagnosis and prescribe anything, the exam will want to make sure we've ruled out the mimics.
Always.
The sources emphasize checking a TSH for thyroid issues, vitamin B12 deficiency, which can cause spinal cord degeneration, and an ANA to rule out lupus. And if the presentation is a bit atypical, like bilateral optic neuritis instead of unilateral, or incredibly severe spinal cord involvement, we have to check for specific autoantibodies.
Right. AQP4 IgG and AEG IgG.
Yeah. Finding those points to neuromyelitis to optica spectrum disorders, which is a totally different disease entity.
Precisely. You must rule out the mimics first. Once you've done that and the diagnosis of MS is confirmed through the McDonald criteria, the exam will relentlessly test your management strategy. The key to answering these questions correctly is clearly separating your mindset into two buckets.
Okay, 2 buckets.
Yes. How we handle an acute fire in the emergency room versus long-term fire prevention in the outpatient clinic.
Let's start with the acute fire. A patient comes into the ER with a sudden, severe exacerbation, say, sudden vision loss or severe leg weakness. What's our immediate protocol?
First, rule out a pseudo-exacerbation.
Oh, like the youth off thing.
Exactly. Always check for an underlying infection like a UTI, or check if they have a fever. Because systemic stress or a high body temperature can transiently worsen old symptoms without it being a true relapse.
Okay, got it.
If you've ruled out infection and it is a true, new acute relapse, the first-line treatment is high-dose IV methylprednisolone. We're talking massive doses, typically 1,000 milligrams a day for 3 to 5 days, to basically slam the brakes on the inflammation.
And what if the steroids don't work? Like the symptoms are incredibly severe and refractory.
Then you escalate to plasmapheresis or plasma exchange. You physically filter the patient's blood to remove those rogue circulating immune complexes and autoantibodies.
Okay, so the acute fire in the ER is put out. Now we move to the outpatient clinic to prevent the next fire. This is the complex world of disease-modifying therapies, or DMTs.
Yes, and there are quite a few.
There are several tested on the exam, and just memorizing lists won't cut it. Understanding why they work is key. For example, natalizumab. I always pictured natalizumab as a giant bouncer at an exclusive nightclub. The nightclub is the central nervous system.
I like this.
Natalizumab is a monoclonal antibody that binds to integrins on the white blood cells. It essentially blocks leukocyte adhesion to the vascular endothelial cells. It stands at the door of the blood-brain barrier and says, you are not on the list, you cannot stick to this wall, and you cannot enter the CNS.
That is a highly accurate and memorable way to conceptualize it. It stops the invasion before it starts. But what about glatiramer acetate?
Well, the textbook simply calls it a ligand for major histocompatibility complex molecules, which frankly tells me absolutely nothing about how it helps a patient.
Yeah, that's not very helpful. Think of glatiramer acetate as a decoy.
A decoy?
Yeah, it's a synthetic polypeptide mixture that structurally resembles myelin basic protein. Because it looks so similar to myelin, it distracts the immune system. It acts as a decoy ligand, drawing the T cell's fire away from the actual central nervous system myelin.
Oh, wow. That's clever.
It's administered subcutaneously and is generally very safe and well tolerated, but the vital caveat for the exam is that it is totally ineffective for progressive forms of MS.
Good to know. Another one to recognize is mitoxantrone. This isn't a targeted bouncer or a clever decoy. It's a heavy hitter. It's an IV chemotherapeutic agent that non-specifically suppresses the immune system by affecting DNA repair and RNA synthesis.
It is very strong.
Yeah, and because it's so systemically toxic, its use is severely limited by major adverse effects, most notably alopecia, hair loss, and amenorrhea. But fingolimod stands out to me here. It's an oral medication, which sounds absolutely fantastic for patient compliance, but the monitoring requirements look incredibly intense. Why are we suddenly hooking a seemingly healthy young MS patient up to a heart monitor?
Ah, that is the classic fingolimod trap. You have to understand the mechanism. Fingolimod traps lymphocytes in the lymph nodes by modulating sphingosine 1-phosphate, or S1P receptors.
Okay.
The problem is S1P receptors aren't just located in the lymph nodes, they are also heavily expressed in the cardiac tissue.
Oh, I see where this is going.
Right. Modulating them can cause significant, dangerous bradycardia, especially right after the very first dose. So you must actively monitor a patient's heart rate when initiating this drug.
That's a perfect exam vignette. The question will ask for the most appropriate next step in management when prescribing fingolimod, and the answer isn't a blood test, it involves cardiac monitoring.
Exactly. You also need to watch for lymphopenia and hepatotoxicity with that drug. And as a strict general rule for many of these powerful DMTs, you must remember to counsel women of childbearing age to avoid certain high-risk medications due to their significant teratogenic potential.
Which brings us perfectly back to our opening hook and the final phase of any clinical vignette: prognosis and patient counseling. You've treated the acute flare with steroids, you've selected a DMT, you've monitored their heart rate, and now the patient is sitting across from you asking, what does my future actually look like?
It's a tough, nuanced conversation to have. Long-term disability in MS doesn't usually happen overnight from a single attack. It stems from the gradual accrual of residual symptoms after multiple relapses over 10 to 15 years.
Right.
Eventually, many patients transition from relapsing remitting into secondary progressive MS, where the worsening is gradual and continuous, independent of any discrete acute relapses. However, the prognosis varies wildly from patient to patient, and the exam will want you to recognize the specific clinical factors that point to a better or worse outcome.
Let's run through those and solve the mystery from the start of the deep dive. We mentioned a patient with painful, blinding optic neuritis versus a patient with a mild gradual tremor or muscle weakness. Why does the exam consider the sudden blindness to have a better long-term prognosis? It sounds entirely backward.
It does sound backward, but it all comes down to the difference between acute inflammation and permanent neurodegeneration.
Okay.
Favorable prognostic factors include female sex, younger age at onset, a relapsing remitting course with long intervals between relapses, and initial symptoms being strictly sensory or visual like our patient with optic neuritis.
Because sensory-driven inflammatory episodes tend to recover.
Exactly. Acute sensory-driven inflammation can be severe in the moment, but the nerve often recovers quite well once the inflammation subsides and remyelinates.
Oh, that makes sense.
On the other hand, unfavorable factors include male sex, older age at onset, a primary progressive disease course, prominent motor or cerebellar symptoms like ataxia, tremors, or that gradual leg weakness, and a high initial lesion load on the MRI.
Because that insidious motor degeneration often implies a fundamental failure of the brain's repair mechanisms. It suggests permanent axonal neurodegeneration right from the start, rather than just transient myelin inflammation.
Precisely.
That totally makes sense. If it's just inflamed, it can heal. If it's quietly dying, the prognosis is much worse. All right, as we wrap up this comprehensive review of the MCCQE neurology guidelines for MS, let's quickly summarize our key takeaways.
Let's do it.
The diagnosis hinges entirely on proving dissemination in time and space. Remember that the 2017 McDonald criteria update saves crucial time because finding oligoclonal bands in the CSF instantly satisfies the time requirement.
Very important.
Keep a close eye out for classic presentations like optic neuritis, INO, and the Lermit sign, but do not fall for red flag traps like seizures, age extremes, or rapidly developing minutes onset deficits. Finally, clearly divide your management mind into acute high-dose IV steroids for the sudden flares and specialized DMTs complete with their specific mechanistic side effect monitoring for long-term maintenance.
And remember that counseling your patient on their specific prognostic factors is just as critical as the pharmacological management. Educating them on what a relapse actually is versus a physiologic thaw-off flare, emphasizing the importance of medication adherence despite the side effects, and managing modifiable risks like correcting vitamin D levels, that all represents the comprehensive clinical care expected of you both on the boards and in your future practice.
To leave you with a final thought today, consider this fascinating pathophysiological mystery from our StatPearls source text. For decades, MS has been almost exclusively characterized as a T-cell-driven disease, those rogue environments breaching the castle walls of the blood-brain barrier.
Right, the outside in theory.
Yeah. But researchers are now discovering something totally unexpected. Intact B-cell follicles actively hiding inside the meninges of patients with early-onset MS. It forces us to ask, how might this recent discovery of localized, entrenched B-cell involvement completely revolutionize the next generation of targeted MS therapies? It challenges everything we thought we knew about where the disease originates, how it sustains itself, and whether the inside-out rebellion theory might carry more weight than we ever imagined. Keep that in mind as you study, and always keep looking for the why behind the facts. Good luck with your exam prep, and we'll see you on the next deep dive.